I'm a professor at Stanford, and I direct OCD clinical research at Stanford. My heart and my passion is really in helping individuals with obsessive compulsive disorder. Like, it's on us as clinicians to really work toward helping people get the most out of these really effective treatments. Not one size fits all. There's a lot of different things, not just medication, not just psychedelics. We're innovating in terms of therapy too. We're combining improv and cognitive behavioral therapy together. How powerful cognitive behavioral therapy with exposure and response prevention is. It is life-saving for a lot of people.
And now I think the next wave is potentially the psychedelics. What do you see happening with that in the future? Hello, and thank you for joining us once again on the Get to Know OCD podcast. My name is Patrick McGrath, and I'm the Chief Clinical Officer for NOCD. NOCD is an online platform for the treatment of obsessive compulsive disorder and related conditions. Check us out at nocd.com, and you can follow the Get to Know OCD podcast on YouTube. I'm excited today to have Dr. Carolyn Rodriguez with me. How are you?
I am doing great. It's wonderful to be here with you.
Thank you for being here. So, Carolyn, for people who are not familiar with you, tell us a little bit about your work and where you're at.
Oh, definitely. I'm a professor at Stanford, and I direct OCD clinical research at Stanford. And
I've heard of it.
Yes.
It seems to be a small college, right? Or something.
Yeah. And really, it's been like a privilege of my lifetime to be able to develop a research program and portfolio that's aimed at those individuals who have tried first-line treatments and haven't found benefit. And where can we innovate in terms of novel medications, novel mechanisms of action? How can we innovate in terms of combining medications with therapy? And how can we push the envelope to using what we learn about the response to those treatments to understand the mechanisms of OCD?
And I want to say, it's tough to talk to you. You're a bit of an overachiever because you have an MD and a PhD. You didn't just stop at one. You went to both.
I like to study. I like to study. I like to learn, and it's fun.
Yeah.
You know. Yeah.
In some ways, we talk to people at the beginning. We have fun questions like about superpowers, and in some way, you've kind of got that. I mean, you've got both sides on the research and on the medical side.
Yes.
What would your superpower be in terms of doing research, do you think, and bringing in all these skills into the research work that you do?
I think the superpower would be the same as my mission in life, which is I want to make an impact in OCD in my lifetime. So I want to have the research and really understand the brain basis of OCD, understand what is driving these obsessions and behaviors, and how can we effectively treat it.
Why OCD?
So actually only in retrospect did I realize why I was really drawn to OCD. And for me, early in my life, I originally from Puerto Rico.
Okay.
And there's a mental illness in my extended family, and I really saw the impact of that firsthand. And as a child, it made me really curious to understand, like, what is making it so that people have these different kinds of behaviors. And in Puerto Rico, individuals are very inclusive and have, everybody's included in the family, but there's also some stigma around going to see a psychiatrist. And so, of course, when somebody says, no, don't talk about something, don't do something, that's all you're interested in. And I just really felt like there was more that I wanted to learn and more that I really wanted to do.
One thing that I think is so important is mentorship, and to have someone who's from Puerto Rico, who's a female, who has an MD, PhD. I mean, what a role model you are for so many people in the field to come up and do this work. So thank you for that. We need more of that in the field.
Yeah,
we really do.
I would agree with you, and I think I have really benefited from the generosity of mentors such as yourself and people in the field who really are looking out and wanting to help and include people and in their careers, and that's very, very important. And so I tried the most I can to really pay it forward, those wonderful experiences that I've had.
coming from that cultural piece where it's mostly in the family and maybe not as talked about much, do they look at you and go, "What are you going to do for a career?"
Yeah. Yes. There was an intervention that was, done. But my family is incredibly supportive, and I think it speaks to the power of education. What you do as part of your mission, really getting the word out, helping people understand what is OCD, what's not OCD, and how OCD can really impact individuals in such a devastating way.
Of course.
And in fact, it was in my early training in medical school where I met an individual with obsessive compulsive disorder, and I was just blown away by how much private suffering there was, and it really drove me to try and understand, like, why did he have gloves, and what's under the gloves, and it was just red and raw hands, and you see the real physical manifestation of that pain. And in talking to him, one of the most surprising things was also the mental rituals. So when individuals have these thoughts that increase anxiety and they have to do something to neutralize, but it's all like a mental ritual. And before speaking to him, I did not even know that was also OCD, and incredibly painful, because these intrusive thoughts were things that were horrifying and were inconsistent with his values. And so he was sitting there with these thoughts all the time, and it really spoke to me. It felt like everybody needs to see and hear about this as much as possible, so we can all really rally around to try and help people.
So you have this event, you meet this person, it's an eye-opening experience. How does that carry forward now into the research you do, the mentoring that you do of students, what you're excited about in the future of the field?
Definitely. So I was like, okay, my heart and my passion is really in helping individuals with obsessive compulsive disorder. And when I went through my training and I was doing the clinical work, I was blown away, first of all, how powerful cognitive behavioral therapy with exposure and response prevention is. It is life-saving for a lot of people. But what struck me is that it's scary to do the thing that you're most fearful of, understandably. And there are very talented coaches out there that can help. But still, even with that, there are some individuals that they just cannot, that the idea of that is too hard. And so it got me thinking, are there gentle on-ramps to help people get the most of the therapy, which we know is the most evidence-based? Some people can do CBT with medications. And, as a psychopharmacologist, medications also have side effects that people don't want to take. They can, both treatments can take a long time, right? So on the order of 2 to 3 months. Sometimes you have to try different medications. And so I was very passionate about trying to think about, if I had a loved one who broke their arm and went into the emergency room, they would need a cast, right? They need a cast to heal the bone. So that's how I sort of think about cognitive behavioral therapy. But you can leave somebody there without pain medications and So I really got thinking about rapid acting therapeutics. Is there something that can kind of knock things down a little bit quickly and be able to help people?
When we're talking about cognitive behavioral therapy, it's obviously going back to early Beck and Ellis and the work that was being done. And it's kind of a broader term these days. And so when people come up to you or ask you about CBT versus exposure and response prevention, ERP, how do you help manage that and the expectations people might have about treatment?
Yeah, absolutely. And the most effective evidence base is exposure and response prevention. So that is the key ingredient. And so sometimes I abbreviate as cognitive behavioral therapy, but I mean cognitive behavioral therapy with exposure and response prevention, or ERP. That's what you want to look for, to get really the best evidence base.
There's so much work being looked at now in new medications or old medications that in the 60s we said we shouldn't use those anymore, and now they're suddenly coming back. I'm excited to learn about like MDMA and psychedelics and different things. What has your interest been in those and some of your research in that area?
Definitely. Well, actually, based on a lot of positive feedback from the International OCD Foundation, which is the largest nonprofit organization
Maybe we're at the conference.
We're at the conference,
I don't know.
yes.
Maybe. Yeah, who knows? Yeah.
It's a lovely conference that includes individuals with lived experience, family, and the leadership team said, hey, we're getting a lot of queries about psychedelics and new treatments. And so I was asked with a colleague to do a symposium. And just by luck of the draw, the topics that I had to talk about with relation to what we understand with OCD, MDMA came up for me, and it had nothing on clinicaltrials.gov, which is where we track active clinical trials that individuals can participate in, and there really wasn't any literature, and I felt like, what a shame, like there's nothing that I can say to answer somebody's question, should I take this, right, or not? And so I started putting together a grant to basically study with equipoise, which means like just not even having a stake if what the result is positive or negative, just cheering on information. Like we want to know either way. If it's negative and it doesn't work, that's just as valuable. Hey, go back and revisit cognitive behavioral therapy another time, or try another strategy, but not this one. Yeah. If it's positive, then it opens up potential and a new possibility. So the trial that we're doing is combining MDMA with cognitive behavioral and response prevention therapy, trying to have a way, a gentle on-ramp to try and get individuals more engaged, bonded, connected with the therapist to be able to get more out of cognitive behavioral therapy. So MDMA, as you may know, is an empathogen and entactogen, and it acts on different chemical messenger systems, including serotonin and dopamine and norepinephrine. And it's a stimulant, and it has this pro-social quality. What is that? Feeling more connected to people. So you can quickly see how that connection may be therapeutically helpful when you are petrified to do the thing that you're most scared of, right? But we don't know. Is it going to be helpful or is it not going to be helpful?
And MDMA, I'm thinking back in the early 70s, it's used for couples therapy to try to get them closer together. But then the rave scene picks up on it and it gets abused, and then we have all these legislations. So I'm excited to see, I always talk about the pendulum's here and then it's here, and what if we just brought it here, right? And we took a look.
More.
And I think what you said about how you do research really goes to the value you described, where you just want knowledge. You want to know. How has that value influenced your career, and how do you try to teach that to your students and the people you mentor?
Yeah, that is a good question. I think, for me, I just had really great role models and mentors, and sometimes just being around somebody and seeing, how they think through things and how they really try and balance. I love the metaphor of the pendulum swinging in the middle, right? That's how you want to think about science. Designing every experiment with, being parsimonious of time, energy. People invest a lot of time to go into a clinical trial.
Sure. So
we want to be sure that that's a sacred trust. We want to be able to provide the information that's going to be helpful no matter what the result is. And to me, that's an ideal design.
And who were your mentors? Who were the people that brought you here?
Yeah, definitely. So, definitely my earliest mentors were my parents and my peers, and certainly when I was at Columbia, folks like Edna Foa, Blair Simpson were incredible role models, and going to Stanford, Laura Roberts and Alan Schatzberg, and you may know him, Professor Emeritus Larry Coran. When I first came to Stanford, was incredibly helpful and generous, and so it's been wonderful to see those examples.
Yeah, and I'm excited too. Just even the connection we have. One of my interns then went out and worked, in some areas with you as well too, Yuri. It just so exciting to see that connection go on, and her joy of working with you, and when she would call and say that. So you have influence people that way, and I want you to know that. And
thank you.
They've really appreciated it as well.
Yeah. I think, and I strongly feel that a mentorship is bidirectional. Like,
Yeah.
you learn just as much from students and peer mentors as you do, right? It's a mentorship is, goes both ways, and it's been really helpful to really hear and be part of the IOCDF community. And, I've gotten really wonderful research ideas from individuals with lived experience,
Sure.
trainees, and really just being open to hearing a lot of different things, to really think about what is the most important question we could be asking clinically, and what's the most important question we can be asking about brain mechanism.
Yeah. With so much work originally being done on, we went from tricyclics to SSRIs. Then we have the atypicals come through, and now I think the next wave is potentially the psychedelics. What do you see happening with that in the future? Where do you think it can go, and what can it give us that's additive above what we have already?
I think that, for me, definitely in training, the serotonin SSRIs were really, transformative to see that wave. And then, as you mentioned, then, I think the next has been sort of glutamate modulators. So a chemical messenger that's a main excitatory chemical messenger in the brain. And then now with the psychedelics, these are different classes of medications. And they have, to me as a clinical researcher, it's really important to hear what people are doing and experiencing, and getting people the most information possible. With psychedelics, I am optimistic, but I would like to see the data.
Sure.
And not just the data, I would like to see it replicated. And I would like to see the safety data, right? Because a lot of these drugs can be drugs of abuse. And so that excludes people who have comorbid OCD and substance, and sometimes individuals feel like they don't have hope and need to medicate in other ways. So I have, I'm pro research, meaning let's see what the data says, and let's see if it can be helpful. But with being conservative about wanting to help patients see what the state of research is, what that means for what they want to try, and then encouraging people to really try the evidence-based treatments first.
I'm betting at times you've gotten pushback. This happens in our field where someone's had a personal experience with something, and then they're angry at you because you're not supporting that, because maybe we don't have the research on it, right? And so I appreciate your want of the research and the knowledge, because while there's nothing wrong with a single case experience, we don't know it's replicable, right? And so how do you kind of help people navigate that notion of let's make sure that we're put the brakes on a little bit and hold our horses?
Well, I think there's something behind the anger, and I just say I'm angry too. I'm angry as a clinician that I can't help you relieve this right now. Let's work together. Let's really think about it, starting with evidence-based treatments. And as you know, half of individuals will be helped by an SSRI or cognitive behavioral therapy, and using the American Psychiatric Association guidelines of augmentation and different kinds of things, and augmenting with cognitive behavioral therapy, 8 out of 10 will be helped. That's great news. And so my research is really focused on those, other folks that aren't helped by the full algorithm, and not one size fits all. There's a lot of different things, not just medication, not just psychedelics. We're innovating in terms of therapy too. We're combining improv and cognitive behavioral therapy together. That was a nice smile.
Go in my area, I love it.
To make it more fun, right? Like, it's on us as clinicians to really work toward helping people get the most out of these really effective treatments. And if not, innovating in other spaces. There's neuromodulation, and as a sort of further line, surgery as well. But that comes with risks of surgery. So.
Yeah, I'm excited to see those other things like improv and comedy that comes in the sense that it's almost an ERP experience, right? We're asking people with OCD to be yes and, right? It's just I'm afraid, yes, and I'm still going to go do the thing I'm afraid of, right?
Yes.
How
like me doing this interview right
yeah,
now.
right. There we go. Doing
yes,
great.
and thank you.
Okay.
Okay.
No. But how has that influenced you? Because I have loved, I told you this story, but a little bit recap. One of the best things I ever did for my public speaking was to take a stand-up comedy class.
Oh, wow.
And the final was to go to a comedy club and do a 10-minute memorized routine. You can't see anybody, the lights are in your face and everything, and you're just listening. And one of the best things I learned from my comedy teacher was a groan is as good as a laugh.
Oh.
You want a response. And now I think about the work we do and the research. We're looking for responses, but we can be agnostic almost to that response. It doesn't have to be a good one or a bad one. It's a learning response, right?
I love that.
Yeah.
I love that. So true. The idea of you, I had an image of you up on stage and I was sweating. So good for you that you could do that. That's great.
Yeah. How has that then come into the work that you've done? What kind of things have you done with improv? I'm really excited to learn about that.
Yes. So I have a talented student working with us, Elizabeth Andreff. She actually presented at the conference, and she does improv, and
That's great.
she's really interested in OCD, and she thought, like, why don't we put these two things together and bring in contaminated objects into the improv exposure. So she's just about to launch that, and we're excited to just see. Again, maybe it's helpful, maybe it's not, but we'll definitely have fun.
You will have a lot of fun with it,
Yeah.
What other things excite you about the future, where you can see things going with in your lab or even other labs as well too?
Yeah, definitely. Well, we have a wonderful partner with the Stanford Center for Digital Health, and a postdoctoral fellow, Ji-Young Kim, was really interested. I communicated with her this really sad statistic that individuals with OCD, it can take on average 14 to 17 years between the time that they first have symptoms to now, and it happens all the time. And when I, in the Stanford OCD clinic, I'm talking to a patient, and they're, 14 years ago I had this, and I was like, my goodness, I can't believe this is still happening. And so, out of anger and frustration, I said to her, what could we do, And Anthony Pinto and a student of his, Kim, have published these series of 19 vignettes that they've given to primary care doctors with the different themes of OCD, and they ask a simple question: what is the diagnosis here, right? And 50% of primary care doctors get OCD correct out of those vignettes. Doctoral psychology students do much better, 82%. So we asked, and they did this with clergy, and they did this with APA members and all these different groups. And with Ji-Young, we asked, what about ChatGPT, Gemini, all these different kind of apps, large language models. What do you predict was the accuracy
of ChatGPT?
Yeah.
I'll go 60%.
It was 100%.
Really? Wow. It
knocked me off my seat, and I was like, that can't be, right? Like, maybe it's pulling in these papers that are already published. So I was like, okay, let's think of new fictional examples. So put it in. What do you think it was?
Still 100%.
100%. And then I was still, this is the scientific method. I'm like, no, this can't be. What if it's like a fluke chance? So we asked ChatGPT, you can do this thing called prompting, and you can ask it, what is the reason why you chose this and not this list of other mental disorders? And then we had two raters look and see, what is the clinical reasoning? How good is it at actually thinking through that this is OCD? And it was superb. So I think it's got me more excited. I was initially a little skeptical, but it's got me excited and wanting to now translate that in a PHI compliant, IRB approved way, pilot testing. If we can really take it to the next step, can we use this? Can we actually have these things help clinicians as in an automated way, maybe even just by looking at the text messages or what's in the content, and helping just to ping primary care providers. Hey, this person, really, you might want to refer them to get an evaluation and get treatment.
What a great experience for training as well, too, because you could present this to the ChatGPT and a trainee at the same time and see their rationale versus this is what ChatGPT pulled and this is why it did that. So
I love that. That's a great idea. Taking notes.
I'll happily co-author
Let's
that
do it.
with
Let's
you.
do it.
Let's
Yeah.
That's good.
Yeah.
You also mentioned, there's the surgical side, and you have the MD piece of you as well too. I've sat in on 2 deep brain stimulation surgeries for OCD.
Amazing.
We have gamma knife. We've got deep TMS. Are there other things at all on the surgical side that are being investigated for OCD?
Yes, I think you named them, and I think, I too have seen an individual go through and what a life-changing experience it was to be able to have that. So to me, it really signals hope, right? Like there's a lot of algorithms, a lot of things to try, and with each passing year and as the years pile up, the pace and I feel like the trajectory of where OCD is really exponentially growing. And I think that there's a community of people who are like, we want treatments, we want research, and that rallying cry is what is needed to make an impact in the field.
There are other conditions I assume you work with as well too. Do you take some of what you've learned with OCD and apply that to other things as well?
Yeah, absolutely. So I also work in hoarding disorder as well. And what's interesting is that hoarding disorder used to be part of obsessive compulsive disorder. A little bit of a fluke by chance, I think, because there's an instrument called the Yale-Brown Obsessive Compulsive Scale that includes as one of the items in the checklist collecting items. And so that piece kind of became part of OCD.
And
but as a
in
clinician,
the OCIR too, I think they had a hoarding question as well.
Exactly.
From the compulsive work group, I think. Yeah.
Exactly, exactly right. And so it was sort of thought to be together. But when I was training, it was really seen as in a clinical research that subtype wasn't as helped by the treatments that were OCD specific, which makes a lot of sense now. But at the time, it seemed like it was together. Whereas now, people really see that hoarding disorder is characterized by a strong attachment to items and clutter that fills the living spaces, so you can't use the kitchen for cooking, sleeping in the bedroom, causes lots of distress. So those pieces are really what hoarding disorder is. It's not characterized by intrusions and intrusive thoughts. People really enjoy their items, and they're fine.
I've often said people with OCD say thank you for seeing me, and people with hoarding often say please get off my porch.
Yes.
So
yes. I think that piece is a treatment, a goal of treatment, right? To ally and say, what are the things that would be helpful for you? And oftentimes it's just very touching, is like a grandmother who says, this clutter that I have in my home doesn't allow my kids, grandkids, to come and visit with me.
Such a common one.
Such a strong motivator. And it is hard. It's hard to let go of an item that is sentimental value and maybe it could be useful someday or is just beautiful.
Why do you think the medication work on hoarding hasn't been as good as we've seen in others? That we still don't have a fantastic regimen yet on the hoarding side of it?
Oh, the medications for hoarding disorder?
For hoarding,
Yes. So there is no FDA-approved medications for hoarding disorder. That's a sobering thing for me to say when I present on hoarding disorder.
I agree.
There's open-label studies of things like paroxetine, venlafaxine. A couple of the stimulants have been tested, but these are small open-label study, which means that there's no randomization, like a flip of a coin, and you don't have a placebo control. So there's a chance that somebody is just taking the medicine and being like, I'm better now, right? And so that's why the gold standard is these randomized trials. There's none for hoarding disorder.
And the way that you describe, say, MDMA, I'd be worried about using
Yeah.
that in hoarding. If it helps with attachment and hoarding,
Yes.
you're so attached to things. I would
Yes.
think maybe we don't want to.
Yes, yes. Although it is, that's
know.
interesting. We don't know, and
Right.
it is an interesting question because it's pro-social, right?
Okay.
And individuals with hoarding disorder are very attached to their objects, right? And some people would
yeah.
even say, sort of, you know, it's hard to have social connections, and sometimes
You're right.
it's a little bit of a fortress, right? To kind of keep people away.
You're right.
Sometimes,
You're right, yeah.
in some cases. And I have seen in some cases, as the clutter starts to go down,
Mm-hmm.
people it's hard. There's a lot of emotions that come up about sort of re-engaging with people.
Our
So
second co-authored paper here. Is yours. It's what we
we're
wanted.
getting
Yeah.
it done. Yeah,
We're just doing
yeah,
it.
yeah.
Where do you hope you can bring the field to? I mean, what is your legacy?
Yes.
You know, you're 20, 30, 40 years from now.
Yeah.
Hopefully
Yeah.
you live forever, but none of us get that
Yeah,
chance.
yeah.
But you know, if you're looking back, what are you most proud of in the work you've done?
Yeah. I have to say that long ago I exceeded my own expectation, meaning like going to college was like such a special thing that I feel like graduating, that was amazing, and everything else has been like kind of bonus. And so I would love to just continue innovating, continue doing the research to try and understand what medications could be helpful, how to combine medications with therapy, and just relieve suffering, make people's lives better, balance with hope, right? What's new? What's new for the future? We really want to be innovating and thinking about that. And in addition, on the technology side, helping to automate what is a recognition of OCD symptoms and get people to care faster.
Yeah.
Yeah.
There's people out there right now who are treatment resistant. What will your research do to hopefully change that, or to even decrease that 14 to 17 years? What do you
Yes.
think it has the opportunity to do?
Yes, absolutely. It gives people more of a runway to try evidence-based treatments, and also, you know, there's other potential for, you know, some of the work that we're doing in ketamine, for example. In animal models, ketamine is thought to increase brain-derived neurotrophic factor and increase plasticity. So if there's a way to increase the brain's ability to think and grow and change, if people are kind of stuck in this OCD brain circuit gone awry, do some compounds open up that ability to learn extinction learning, which is one of the fundamentals for cognitive behavioral therapy, to learn new models of thinking, to be able to take a step back. So some folks that have gone through our ketamine study, albeit briefly, experience relief from OCD, they can sort of see more, oh, this is me, and that's OCD. And that's not often the case for people. They've had OCD integrated as part of their identity for so long that even just, you know, a window back into sort of what is OCD for themselves can be an insight. So
There's a lot out there about, you know, who's done treatment, if they've done enough treatment, how much treatment, when to do treatment. There's notions about treatment resistance versus failed at treatment. You obviously, with all the research and what you do, and your students probably have these discussions in labs and things. How do you approach that?
Yes, I don't love the term treatment resistant because I feel like it's non-specific, and it's not honoring individuals' preferences as well. I feel like it's important for patients to know that there are several first-line treatments in the field, including ERP and medication management with serotonin reuptake inhibitors, or SSRIs. So we want individuals, at least for research, to be able to have the opportunity to learn, know about these things, and either try them at sufficient rates. So SSRIs, you want to do it for higher levels than you would for depression, and for long periods of time, 8 to 12 weeks. And you want to have ERP that is the evidence base. So you want to have hierarchy, homework between sessions. So those are the kind of things. So we have high quality trials then there's algorithms that you could try other variants. You can actually also increase the dose of ERP. You can do it instead of once a week, twice a week, just like you would increase the medication. So I like to have people really try those evidence-based treatments, try different medications in an algorithm that is, for our field, that has been designed and developed before moving on to other things. So resistant is a difficult word for me because I have so much hope, and there's so many different things to try.
And I like we said too, we start everybody at twice a week sessions. We have found that front loading is really, really important.
Yes.
One other just quick piece on that, on the medication side. Many people will just go to their GPs for meds who will not go to those higher levels. And then maybe feel like, well, I've tried treatment, but it failed, right? So could you speak a little bit more to the dosage levels versus on an antidepressant and the depression level versus the OCD level?
Yes, absolutely. And there's wonderful guides out there. So there's the American Psychiatric Association has a treatment algorithm. The ADAA, we did like available online, a clinical practice guidelines that have the dose ranges, and they're much higher in OCD. And so you're exactly right. Sometimes individual treated as if it was for depression, and they're not getting the right dose, right? And that's hard to see. And then once they get up to a high dose for longer periods of time, it can make a difference.
Part two of that. There are people out there who are still struggling. We're here at the conference. People come up to us as professionals all the time. What's your go-to advice to people or to families when there is that stuck point with OCD?
Absolutely. So I would say, education, getting as much knowledge as possible about where the field is, support for each other, putting on your own oxygen mask, right? Especially for family members. It can be really tough. And there's a lot of strategies and techniques that are available to families to help, be supportive in a therapeutic way with their loved one. So that's really important.
And I also, what I see a lot too is, I think also helping those other people in the family manage their own emotions too.
Absolutely.
This doesn't go as fast as they want, and they can get easily frustrated in things too.
Absolutely,
as well.
Absolutely. I heard a phrase: "You're only as happy as your least happy child," and so parents really feel this in their heart, in their body, and so really making sure that we can get the oxygen mask on the family members is really important.
You're right. Well, I want to thank you for being here today. This was a joy to have some time with you.
Oh, thank you. And thank you for all of the work that you do. Again, I'm a big fan. I've seen you in the field, and just the way that you're so welcoming to junior investigators and trainees, and just really wanting to provide education and support. Just big fan.
Thanks.
So thank you.
Appreciate it.
Yeah.
And thank you everyone for watching another episode of the Get to Know OCD podcast, brought to you by NOCD. You can go to nocd.com and check us out. And if you want to follow us for other Get to Know OCD podcasts, go to YouTube and go to the NOCD channel. We'll see you again in the future.